Hello and welcome to this session on how innovation is healing healthcare. And we'll be looking today at the groundbreaking work of the Centre for Innovation, Transformation and Improvement at Guy's and St Thomas's with three of the key players. We'll be talking about how the NHS is moving finally well beyond the fax machine with fascinating projects on remote monitoring with the aim to provide better care, quicker, cutting waiting lists and helping less developed systems around the world. So we have lots to talk about today. I'm Hannah Kuchler. I'm the Global Pharma Editor of the Financial Times. I lead our team covering medicine, science, and before I started reporting on healthcare, I was a tech correspondent in Silicon Valley. I'm excited to welcome, starting from the left, we have Sarah Williams, a GP who is also a Clinical Innovation Fellow at Guy's and St Thomas's. And then we have Chris Spellman, the Director of Delivery and Transformation at the Centre, and Shaheen Khan, a consultant in palliative care and the Clinical Director for Integrated Local Services at the Trust, and we're going to find out what that means. So we're going to speak for about 45 minutes, and then we're going to open up to your questions. So please have your thinking caps on. I'm sure you've got better ones than me. So first of all, I think it's probably a good idea to start by defining what we mean by remote care. Some of people may feel like they experienced some telemedicine during the pandemic, even just by phone calls and things, but what does it look like now before we move on to what it'll be like in the future? I don't know if, Chris, you want to start us off?
Yeah, sure. I guess at its most basic level, remote care is about using technology to provide better, faster, fairer healthcare, which is the kind of the mantra of the Centre for Innovation, Transformation and Improvement. And lots of people will kind of challenge you around that statement of, well, that's not going to work for everyone. And actually, that's very true. But what using that technology for the appropriate patients means that you can wrap a load of resource and effort around the higher risk patients, those that will always require face-to-face care. And this is not something that we're pursuing because it's fun and sexy and innovative. It is a question of necessity. The waiting lists for the NHS now are in excess of 7 million people. Some work from the Health Foundation recently estimated that the NHS would require an additional 500,000 staff if it were to reduce the waiting list back to pre-pandemic levels. So even if that were financially achievable, those people don't exist. You will have seen well publicised the workforce shortages in the NHS. So remote care is about using technology across a huge spectrum. You'll hear from Shaheen around the hospital at home service and what that means, through to quite simple and relatively low cost remote monitoring devices that allow us to continually or periodically monitor people with, in particular, chronic conditions. So rather than having to come back to the hospital on a kind of calendar basis, a very sort of traditional way of delivering healthcare, we can use that technology to identify patients that may be deteriorating while they're waiting, but also patients that are doing really quite well and can actually potentially be managed in the community or entirely independently. So it means an awful lot of things. It can be very complicated to very simple.
So the opportunity really is not robots replacing doctors, it's kind of empowering doctors to keep an eye on people in a more thorough way, and even when they're still on the waiting list.
Yeah, that's exactly right. And not necessarily robots, but certainly machine learning and large language models at the moment don't play a role in the work that I'm leading. But certainly that initial screening of data to direct human doctors towards those most in need is definitely something that will be happening.
Great. And Shaheen, what are you working on now, right at the Trust?
So at the moment, there's a lot of national attention on the concept of virtual wards. And I think there's a risk with the terminology that it's open to misinterpretation, whether that's virtual wards or remote care. Because in many ways, what we're talking about is just part of the patient pathway. In some ways, there's nothing virtual or remote about what we're doing because it still involves that human interaction with the person. It's just that perhaps more of it in the past needed to be done in person within the four walls of a hospital, where not just the patient but also the staff member felt a bit more comfortable. But just to give you a flavour, today, for example, as a doctor, I was out doing some home visits, And where we are now with our virtual wards capability is that one of the patients I was seeing has got very unstable diabetes. He's being looked after at home. And if we go back even a year or two, he would have needed to be in an inpatient hospital bed because of the frequency of the blood sugar checking, the intravenous medicines and fluids that he's needing. Whereas now we're able to do much of that from a distance. We don't necessarily need to send a nurse or a doctor in 4 times a day to check the blood sugar. That can be done by the person through some wireless technology communicated centrally, and then we can respond to that person when we need to. But also by using technology to help the pathway, we can spread our clinicians more thinly across a much greater patient population. And I think the key thing is to use the technology to augment the existing pathway rather than implementing technology and then building a pathway around it, if that makes sense.
Yeah, that makes a lot of sense. And obviously, and we will definitely get to this later, you know, what you're doing has not necessarily been scaled across the country yet. But if this is what you can do now, what do you think the future opportunities are, Shaheen?
I think the future is largely around putting as much power and control where appropriate into the hands of the public and our patients. Not just when they're acutely unwell and in crisis, but also that wider population health agenda. So how can we use technology to help people with things like smoking cessation, weight management, management of blood pressure, attention to mental health. And I think we've got the opportunity with AI, with machine learning, to really harness that data in using big data in the true sense, to then start to affect population health management as well as attending to the needs of the individual person in front of you.
That's really interesting. That's definitely something that's been an aspiration for a long time, but not quite got there. Sarah, Shaheen was talking about how, you know, you can remote monitor someone who was clearly in reach of the hospital because he got there today. What about using it for sort of further flung places?
Yeah, so definitely a little more remote, some of the work that we're working on with especially one of our providers that's an augmented reality platform. And the benefit obviously of remote is geographical boundaries are just completely blurred. And in COVID, that was obviously one of the big initiators for why that happened, because people couldn't move. And one of the examples that was amazing during COVID and was covered quite widely was one of our clinicians, a surgeon, had wanted to do a procedure with robotic surgery. So robotic surgery is not, as some people might think, the robot doing the surgery. It's the clinician actually moving the robot from a console in the corner. And one of the benefits of doing that and having the visual part of that is that someone else could actually come in and see what they were doing and direct them. So there was a 31-year-old gentleman who had testicular cancer and it was spreading. It was going to be a really complex operation based around a couple of blood vessels that are really important. And our consultant in GSTD, experienced but not experienced enough in robotic surgery, thought this patient needed it to be done robotically so that he didn't have the inpatient stay during COVID. And so there was a medical director of robotics in Seattle who sat in his dressing gown and actually dialed in and was able to then direct our surgeon really safely as to how to do this procedure. And that's just amazing, the sharing of skills across that boundary. I mean, no one can be an expert in everything, and to be able to access that skill and that knowledge remotely is amazing. And one of the things that I'm working on in my role in CITI, which is quite a broad role, and this is one of the parts of it, is that we have a surgeon who has a contact in Kenya. We get a lot of people visiting Guy's and St Thomas to come and train with us, and in a subspecialty of surgery called vascular surgery. He came and trained, but then returned to Kenya and was actually the only person trained in those procedures, but still quite junior, right? He's only been to Guy's and St Thomas for a few years. So the team in Guy's and St Thomas want to continue to support him as the only surgeon there. So what we're doing is we're setting up a partnership between our team in London and the team in Kenya so that they can then remotely mentor him through those procedures. And we can talk a lot about the educational benefits. So the patient outcomes are obvious. The person gets their procedure that they wouldn't otherwise have been able to have, but actually the educational benefits are huge as well of being able to do that. If we had just done that in person in the theatre, the old school used to have theatres where people would sit around the room and look in, but even then you could only have kind of tens of people. And nowadays, like as a medical student, I'd have to crane my neck over the person in front of me, whereas now you can get hundreds of medical students dialing in, watching the procedure, and you can talk to the surgeon at the same time and be talked through. So there are just so many exciting things that are coming from that real remote care that we're doing with that too.
Wow, yeah, that's amazing. There's that place actually opposite Guy's where it shows you the old surgical halls where you can go and look down like that, yeah. Yeah, we definitely come back to the education aspect because I think that sounds really, really important. But Chris, I wanted to pick you up on what you were saying about the waiting lists, because as you said, like, you know, me and my colleagues and in the press write about these all the time because they seem really intractable at this point. What is it, you know, how do you approach doing remote care on a waiting list, and are there things that we're doing that maybe we're not doing yet that maybe we could?
To give a specific example, you'll hear lots of clinicians talk about, you know, if they could only see the right half of the patients that are on that waiting list, that, you know, their job would immediately be 50% easier. And then you also need to factor in for lots of the people that are coming in for care or coming in for an appointment, it's not of any value. It's actually, you know, it's quite stressful, it's expensive, we're in the middle of zone 1, it's disruptive to people's work. So there's lots that we can do to actually identify the patients that really do genuinely need that consultation. So some of the work we're doing around risk stratification, particularly with our diabetes population, is analysing the data that we hold on those patients and identifying patients that are deteriorating from those that are doing well. And then that allows us effectively to pull forward patients that we can see are deteriorating. And the recent pilot that we've just completed in diabetes identified that 40% of those patients that we call red flag patients that we move up the queue would have suffered clinical harm if we'd have left them in their original slot. The other thing that's quite interesting about that pilot is actually the reaction of the patients that you phone up and talk about whether they do need to come in for their appointments, and actually explain that based on the data that you're looking at, they appear to be doing well, and obviously validate that through that conversation. My assumption was actually that would be a very difficult conversation in most cases, and people would say, I've been waiting for 6 months. And actually the reality was very, very different. Patients were not only incredibly understanding that they were potentially going to wait a little bit longer or not need the appointment in place of a higher risk person, they actually they found that very empowering, the fact that they were often managing their condition well. So it really is about using risk stratification or identifying those most in need, so we're seeing the right half of people.
Do you feel like there's a risk in risk stratification, that you will be, you know, blamed for not spotting people in the right way?
I guess there is always a risk, and I'm sort of being very, very sort of open about the pilot. There's actually normally far more clinical variation between the doctors than there are between the rules that you develop. So generally, the algorithm is much more accurate than Shaheen and his colleagues agreeing. Sorry, Shaheen, but the maths aren't with you.
Yeah, I'm not sure if that would fill the patients with confidence if you explain that. But yeah, Shaheen, can you talk a bit about where, you know, okay, you've got them off the waiting list, that they're in your care. Are there ways that this can actually make healthcare more effective?
I think the short answer is yes. I think one also has to look at the reasons why the waiting lists are increasing so much. So there are some very valid capacity resourcing questions, of course, but also thinking about the population that we're caring for now. We're very fortunate that people are living longer, well into old age, but during that period, people are picking up more long-term illnesses. So actually what you find is someone's not just on one waiting list, they might be on several waiting lists and known to lots of different teams. There's also a real difference in the interaction when you see someone in a clinic versus, for example, in their own home. And so, you know, there are lots of scenarios where people might turn up to a clinic and you see them for 15 minutes, half an hour, or if in primary care, even less. But then they go back to their house and collapse in a heap because it's taken all of their energy for the whole week to present. They'll be wearing their best clothes, they'll be doing their hair properly to present their best possible self, because they feel that if they don't do that, they might not be deemed well enough to access disease-modifying treatments. Whereas when you see someone in their own home, you're on their patch, it's their terms, you're in their living room or their bedroom, it's their environment, their rules. And actually, that dynamic is completely inverted, and I think that puts a lot more power in the hands of the patient. The other thing with the risk stratification, I think there are some caveats to that, and I think it does feel a bit unsettling to start with, but then if you think about it, we're not in a zero risk environment. There's huge risks for people who perhaps are sitting on waiting lists for months or years in some cases. And also there are some safeguards around things like patient-initiated follow-up, where you can actually, in the right sorts of conditions, give the patient the responsibility that if X, Y, or Z happens, here's a number you can call and we will commit to seeing you within a week or within a month. And also giving colleagues in primary care or secondary care that reassurance as well, that they don't need to wait for 6 months to be seen. They can just phone in directly and get some telephone advice.
Yeah, and I can imagine that being reassuring as well, because sometimes it can actually feel hard to know how to access your doctor. So yeah, that makes sense. Now, Sarah, let's go back to that point, about education, but a bit more broadly. Obviously, are there ways using education that you're going to make care more effective?
The education will make the remote care.
Using remote care as a way to kind of improve education of the workforce will also help the knock-on effect of making the healthcare more effective.
Absolutely, yeah. So I didn't train in surgery, but had to undertake some surgical time. And for people who need to have viewed or partaken in a certain number of procedures, then that's a very useful way to be able to access those. Not only just people who are close by, but actually people in rural communities, people who are, and we spoke about Kenya, but I'm talking nationally at the minute, people who are, for example, if you're a MaxFax trainee, it's a more specialised area, you've got to travel in your training around lots of different hospitals, and actually that's really disruptive to life and can be really difficult.
What is that then?
Sorry, maxillofacial surgery. Okay. And it's just there are fewer patients, and therefore you need to train among more different hospitals to get your experience, which is what everyone needs to get. Additionally, when you're, as I was saying, you can communicate with the surgeon, which is amazing. I mean, my time in surgery, you might be able to chat with the surgeon a bit, but generally there's a mask on and they're kind of muffled. But with the technology now, you can actually direct questions, and quite happily they'll be able to answer them. So the knock-on effect will be hopefully a workforce that is more confident, having experienced more, and being able to do more specialist procedures as well. But equally, there's actually a whole training aspect of it that can bring in AI and machine learning. So if your procedures are recorded, you can then, they're developing a machine learning AI that will be able to assess your performance based on the recording of your procedure and tell you, hey, last time you actually moved your scalpel slightly this way, and that was better, so maybe next time. And so actually doctors and surgeons are really enjoying being able to review their own training and say, oh, amazing, I can actually learn. And we're wanting to develop kind of virtual training logs and ways of assessing our performance based on that. So it's all from even just experience and exposure all the way through to really specific and specialized training that it's going to have hopefully a really big impact. And lastly, obviously, the Kenyan point, where people who are in areas where they're not able to access training because of the resources, there's a virtual fellowship that I think we're the first in the country to start a new virtual fellowship. So it's really expensive to come to London if you're not, and if you're based here actually, but especially if you're coming from a different country with a different currency. And so if we can offer that training virtually, then that makes it so much more accessible to so many more people, and hopefully will contribute to narrowing the inequality gap.
It's interesting that you say that surgeons are welcoming this. I can imagine people welcoming it, people liking to compete against their colleagues perhaps, but I can also imagine people feeling like it's kind of big brother in the room with you. So at what point is the data going to be collected against you and used against you in a disciplinary matter? Or has that come up, or is there ways, do you think, to address that issue?
Yeah, I think that is going to be an issue, and I haven't seen any because it hasn't, I don't think, been around long enough for us to have had those outcomes. But I know that there was a survey done that actually said, from a patient point of view, 76% of the patients surveyed were glad their procedure had been recorded because they felt the confidence increase in it. But from a staff point of view, there will definitely be mixed reactions from people who are nervous, and also different staff groups. Because you can have recording of just the procedure, but you can also have recording of the room. And some places in the States especially are having kind of a black box approach to surgery, where for performance metrics, there's even audio recording of the actual surgical room. And having been in surgical rooms, you don't always want to hear what's being talked about, but that's all getting picked up, and it's a very different work environment. And when staff, and we're all concerned about staff shortage in the NHS, and we need to be really careful about how we're using this, and we want to be protecting and helping our staff and not endangering or putting them off at all, or putting more pressure on them.
Yeah, because when you say it's like a black box, that seems kind of reassuring. You know, you can go back, you can work out what's happened. It could also be like a body cam, which again, sometimes is very, very important to work out what's happened, but sometimes also really affects the behavior of the person who's being made to wear a camera. Yeah, lots of interesting issues, which is actually brings me to the sort of the next thing I wanted to talk about, which is we've talked a lot about the opportunities. But, of course, there are many, many pitfalls that we need to think about. And I thought that maybe the first thing to ask, I don't know, maybe Chris, and then the rest of you can follow up, is, when is this not a good idea?
Complexity of pathway is obviously one of the big considerations. There are, particularly if we think about remote monitoring technology around things like spirometry or cardio heart failure conditions, they're really quite established technologies which allow you to sort of safely and continually monitor patients. So sort of picking those high volume, relatively simple pathways is certainly the most obvious thing to do when we're looking at scaling. There are also, considerations to be made around bias that can be introduced in with the technology. So to have all of the appropriate kind of safeguards and balances in around how you do health equity assessments and how you assess the data. So there's lots of checks and balances that you need to make along the way.
Shaheen, what about your experience?
Yeah, I would echo all of that. My dad's a retired GP, and when I was training, I asked him, what's the most important kit that I should carry around in my bag? And he said, it's what's between your ears. And that's really stuck with me. And I think there's over-reliance on technology. That's a risk. There's also the risk of, the concept of digital exclusion as well, and making pathways that unconsciously exclude big segments of the population. And I think there are ways that you can mitigate against that with making sure that patient choice is at the centre of everything. So if you think about what you do now with your banking, when you book a holiday, when you order your groceries, you can still go to a travel agent. You still can go to your bank. Well, sometimes, but for most people, the convenience and the access trumps that. But what you don't want to do is just shut down all of those other options overnight as well. So having attention on a mixed menu for people is really important, I think.
And when you talk about digital exclusion, how much is I don't have a smartphone, or how much is I don't know how to use this, I don't want to use this? At any point, are you expecting people to use something that they've paid for?
So it can be all of the above. So where we work in inner southeast London, we have huge variation in socioeconomic deprivation indices. So we have some very affluent areas, and we also have some patients who don't have a phone. They can't necessarily pay for a broadband connection. They struggle to pay their electricity bill. So if you suddenly then impose loads of technology on them without due care, you're going to exclude them. So I think you need to think about the costs of those things and resource them appropriately, and really uplift everyone to the same level. There's also other risks around this in terms of language, accessibility, reasonable adjustments, and all of those things that you would apply to any part of healthcare, and I don't think technology should be unique from those.
It's an interesting point about electricity and things. I do remember last winter, of course, when energy prices were soaring, there were conversations about like people running oxygen machines at home, and could they afford that? Does that process work smoothly to reimburse that stuff or not?
So the model that we're working on at the moment involves, for the right patient, when they're referred to the service, the kit is provided to them. So it's couriered out to them at the point of them coming on board on the pathway. And that will be customised based on what they need. So they'll get essentially a little box with the relevant pieces of equipment, and where necessary, either a smartphone or a tablet, which is 4G enabled, so it doesn't rely on them having Wi-Fi at home. And so all of that is really self-contained, and they'll be provided with telephone support and training where needed. But despite all of that, there still will be people for whom that's not appropriate, and that's fine as long as you've got something in its place, like a home visit or whatever else is needed. So it's really about that mixed menu. But for most people, you know, it's natural we focus on the risks and the digital exclusion, but most of my patients are far more tech savvy than I ever will be. You know, many of us have got implanted devices. You know, I mentioned diabetes earlier, but we're seeing people now with pumps that are training their nurses and doctors when they see them. You know, this is how it works. This is what you need to pay attention to. So, again, I think some of this can be turned on its head as well.
Sarah?
Yeah, and just thinking obviously about the political context and the social context, I think there's recently read that about 1 million people cut off their broadband because of the cost of living crisis. And so then the service needs to recognise how much we're integrating with a whole other set of issues, and not just the NHS and not just within our service. And I think in terms of inclusivity and exclusivity, they're quite often, you know, what will exclude some will include others, even in the same boat, but slightly differently. So financial, for example, paying for your broadband, but actually that person might then not have to drive or get transport to the hospital. So there's quite often a different balance that comes up. And a really interesting one that's really needs to be thought about and carefully and really sensitively is people who are actually coerced at home and who can't access healthcare services. And one of the things that we're concerned about with digital transformation, obviously, is not to widen the inequality gap, because people already vulnerable can suffer and become more vulnerable. And so one of those groups of people are people who aren't able to leave the home without permission, but equally people who actually want to leave the home because that bit's okay, but they can't have a device. So what works for some may not work for others who look like they're in the same group almost, but there's just such heterogeneity within that we need to be a service that doesn't look to kind of all encompass for the person who needs the most. We need to look to each individual need and be able to flex for that as well.
Yeah, that's really important. That's something I guess that came up during COVID, wasn't it? The idea that, you know, home is not a safe place for everybody. So another sort of big issue that you're intersecting with here is, you know, what's the responsibility of the NHS? What's the responsibility of social care? And what's the responsibility of your kid or your niece or whoever has to look after you? Is there a risk that you do remote care and it's great for the medical stuff, but it's not so good for the care, and that will get slumped on someone else?
Yeah, I'll keep going. Yes, I think this is really interesting. It's like energy moves and creates and is formed, but stays there. And this idea that we're actually just moving the work somewhere else is really important, because we're all, again, part of a massive ecosystem and within healthcare itself. So I know that as a primary care clinician, it can be a concern that people in secondary care, you keep people at home, well then primary care is going to get overwhelmed and get more burden on them. But there are so many different types of burden, and it's about trying to put that in the place where it is most able to be dealt with properly and appropriately. And I think that people are concerned about their own care for sure. The burden on people can be cognitive. You know, if people are in hospital, they don't have to think about when to take their pills, and actually that's one extra burden of being at home, is the cognitive part. And then there's a practical part, you know, but you actually have to go get your pills from the cupboard, and you have to move, and if your mobility is difficult, then that can be difficult. And then there's actually the care itself of decision making. And we actually all do remote care. We all are at home deciding when to access services. A lot of people now have watches or smartphones that are tracking their care in some way. So we're finding a population that on the whole is doing some sort of remote care themselves anyway. And again, it's about providing for those who need it. But there's also something about identity of people at home or in hospital, and there's a burden relationally, I think, on people that in hospital they can be protected from. And I think it's quite an interesting or important point to recognise that people at home, a lot of people benefit from being at home and want to be around those relationships, but other people, and Shaheen will say this a lot, are get really tired at home because they're not seen as unwell, and therefore they are of increased burden on them from families or friends who are well-meaning and wanting to visit, but actually increasing a burden on them that's taken away from them in hospital. So there's many different burdens almost on people that change when you change the service. And I know you'll have a lot more to say about this, but one point is how we create things that actually take away that burden completely instead of moving it around. And some of those things that, for example, technologies like a curable, which is it is a remote care technology, but if anyone's ever had sleep apnea, you have to go to the GP and get, it's a thing where you kind of pause in your breathing overnight, and we need to assess your night breathing. And you've got to go to your GP and get a referral to the sleep service, which is overrun, and it takes weeks and weeks to then you go to the hospital and pick up some kit. It's really heavy, clunky, lots of tubes, and you go home and connect it all up, and then you've got to sleep with it on you somehow. I'm not sure how people sleep with it on them, and then take it back. And what you want is a remote care partly that takes away some of those steps and removes some of the burden. So in this example, a curable has created a little pebble that you can stick on your neck, and you don't go to the hospital, it gets sent in the post, and you don't have to travel, and you don't have to get a referral. Always the GP can do it themselves. And so you want to cut steps and have remote care taking burden away from some of the services rather than repeating the burden in different areas.
Yeah, that was a very comprehensive, but I still feel like you guys have more to say on this, Shaheen.
Yeah, so I think in terms of, practically what does this actually mean for people at home? And we have to remember that hospitals aren't always the safest place for people to be, and this is not about rationing care or stopping people accessing what they need. It's actually about making the smartest use of our overall resources, and that's not always easy, even within healthcare, but certainly across health and social care, where the accountabilities and budgets are quite siloed still. So what's good for one part of the system might create a bottleneck somewhere else. And I think we need to move more towards pooled accountability for clinical outcomes for the population, so that if you go to the emergency department, they'll obviously be focused on dealing with you, turning things around, getting you back home or admitting you. Whereas for the primary care colleagues and those of us that work in the community, it might be more about preventing that happening in the first place. But we've all got different budgets, different KPIs, and it's very hard to join those up sometimes. But practically what we can do now that we couldn't do until very recently is put that control in the hands of patients. So when it comes to doing things like checking oxygen levels, you'll be familiar with the oximeters that clip onto people's fingers, checking temperatures, blood pressure, heart rate, all of that can be done by the person without a clinician needing to go anywhere near them. We can now do basic ECGs, so electrocardiograms, where you have the clips done and monitor your heart rhythm. We can do a 6-lead version, which is not quite the 12-lead version. But again, a person can do that on their own at home and have that electronically transmitted. The other great thing about all of this is that people can do this stuff when they feel that it's helpful to do. So, for example, if a nurse happens to turn up at 11:30 in the morning to take a blood pressure, that's one time in the whole day. Whereas if a person has headaches, palpitations, they feel a bit unwell, they can do that whenever they want and upload that information, and it forms part of that information and context. So I think it's really flipping the dynamic, again, as I've said earlier, that it's what patients want us to know about rather than what we happen to ask them about.
And if I was doing this panel and we'd led with a tech point of view, we would have probably asked the data question already. But of course, there are some people to whom anything that's collecting all this data at home about them is quite a sort of scary prospect. Maybe, Chris, you can start with this. I mean, how do you address, obviously, privacy concerns security concerns, which can be even more difficult. We've seen hospitals targeted in plenty of cyber attacks. And balance that with the fact that this data is useful and you could learn from it.
Well, it's one of the most regulated and controlled aspects of the entire healthcare system. We've just actually, we were talking about it before the panel started, just gone live with our new electronic healthcare record, which actually will bring in a greater level of patient data and transparency, but also a greater level of security. There obviously is huge commercial value in that data, and you know everybody is very well aware of that. Any use of that patient data is always done with the consent of the patient or a patient group if we're looking at aggregating data. And if we're using data for any kind of research purposes, then it's always anonymised in that way. And if we're sort of developing a product, it goes through a full independent regulation and approvals process. So it's an incredibly regulated part of the process.
On the commercial value, I mean, how do you see the extent to which the patients that have participated should receive some of that value? I mean, obviously, on one end of the spectrum, that could be money, but maybe in terms of priority access or whatever.
We would only ever look to collaborate with a commercial partner that we believed was going to develop a product that was going to be to benefit the patients within South East London or the wider system. So I think we would see that translation of value happening through the delivery of improved services, products or drugs, rather than necessarily directly to the individuals. Though of course there are incentives by of taking part in research trials, etc.
Either of you want to say anything on the data topic?
I think Chris covered it pretty comprehensively, but just how much more data you get through remote, as I was talking in the first instance, and through even conversations to gather that data on how to talk to people better. There's so much rich data that can be recorded, and just how useful that is for improving our clinical care. And I think that's really important. And yes, it's very well protected, and that's always kind of top of the list question is how protected is the data. But I think the value of it and that we can gain over time when we best use it. It takes a lot of resource to actually analyse and use it properly, and that's what we really need to be doing is properly analysing and getting its value from it.
Yeah, so that's one of your sort of future ambitions. I'm going to open up to the floor in about 5 to 7 minutes, so if you want to start thinking of your questions if you haven't already. Moving on to these ideas, some of these future ambitions. Sometimes scaling is the hardest part. Like in Silicon Valley, they sometimes call it the Valley of Death, but that normally means you haven't got money for a period. But everything I hear is that actually the NHS can sometimes have a even sort of deeper valley of death, because good at launching interesting projects but hard to scale across however many ICGs we have now. How do you even start that process, and where are you in it?
I think the first thing is to acknowledge the NHS has not been very good at certainly scaling and sharing. The way that we are approaching that at Guy's and St Thomas's, I think, is probably three main things. The first one is we've set up CITI as a standalone specific entity, which means that people like me and Sarah in particular, our day job is to help develop and implement these types of initiatives. The second thing is we've chosen a small number of big things. Remote care is one of them. And then the final thing, and hopefully sort of Shaheen is a good example of this, we proudly want to be the most innovator-friendly organisation in the NHS. So we try to stimulate ideas and innovation from our clinical and academic community, and then we support those through CITI. But we have not been fantastic in the NHS at scaling innovation in the past.
Shaheen?
Yeah, I think it's work in progress. So locally with our virtual ward work, we wanted to partner with a tech company that could help us take us to the next level, because as a colleague said earlier, even if you had an infinite supply of money, there is not an infinite supply of staff, and we have neither. So what we wanted to do was take the next step forward and use technology to augment what we already deliver. So we thought, well, how do we go about procuring this in the most effective way? And that's where, for example, we could then go to CITI and access that central expertise and support, and they essentially led the procurement process with us, and we adopted a standard framework and secured a very effective partner at the end of that. But it's very transparent, which is really important because at the end of the day, we are talking about taxpayers' money. And then in terms of how do we scale it, I think firstly it's important that organisations and teams leave their ego at home with this type of stuff. So there are things like a communities of practice across South East London where we're learning from colleagues who are perhaps a little bit further along the tech journey than us, but they themselves are perhaps not as far ahead in the clinical side of things. So I think learning from other areas is really important, and I think historically in the NHS we haven't been that good at it because everyone's keen to shout loudly about their own service and not necessarily be as open to learning from not just within the NHS but from other countries as well, I think.
And what about making sure it's all joined up even within an area? Shaheen, on the services side, how do you make sure that someone isn't sort of struggling with 17 different services that they're coordinating themselves?
Yeah, so again, work in progress, but just this month, on the 5th of October, locally, we went overnight from having 120 different systems to access for patients down to one. So that's our unified electronic healthcare record, and that's a complete game changer in itself, but also the functionality that has. So in terms of apps on smartphones, not just for staff, but also for patients. So there is now a patient portal into all of this where if a patient wants to, they can download an app and have visibility of most of their healthcare record live, so that if they attend a clinic appointment, for example, and have a blood test, subject to some safeguards, the patient will see the blood results at the same time, or in some cases before the clinical team that's looking after them. And again, that's just transforming the way we're going to deliver healthcare. And then patients can start correcting things as well. So if there's, for example, a drug allergy that's maybe a bit out of date, or a diagnosis of asthma that maybe they've grown out of because it only affected them in childhood, they can then tell their doctor or medical team, actually, you need to adjust my record, and then start contributing their own data, measuring their own weight, linking it to sort of physical fitness, diabetes management, and co-ownership of the healthcare record. So it moves away from being something that we've got your data and we won't tell you about it unless you submit a formal request, to actually, this is your healthcare record, may I have permission to access it because I want to look after this part of your care for a certain period of time.
Sounds good. And anything more on sort of joining up the technology, Sarah or Chris?
I suppose just kind of recognition of how frustrating it is for people to have to access different care from your GP to your secondary care, and so it's really well recognised that is a barrier to people even accessing. And if your technology keeps changing and you don't use it that often, and you've got to keep redoing it, so it's something that is pretty high on the agenda, is to make that fragmentation, and as Shaheen said, base it around the person, because it's very easy to see someone as a diabetes patient or as a rheumatology patient, but we need to see them as the whole patient, and the GP wants to see the records from your secondary care and vice versa. And so being able to base it around you as a person or us as a person is just going to make a really big difference to care and people understanding and having ownership over their care as well. So.
And you've spoken so much about the work that you're doing, but is there anything that you would like government to do to help you scale this work?
The payment system that Shaheen was talking about before, at the moment, effectively incentivises the wrong behaviours rather than the right ones. When we talk about remote care, we're ultimately talking about trying to improve patient outcomes by minimising the amount of healthcare that people have to receive. And the payment mechanism at the moment incentivises you to do more activity, to bring people into hospital, to give them treatment, whether it adds value or not. We do have some control over that now through integrated vertical integration with other providers and setting capitated budgets, but undoubtedly at a kind of policy level, it could be incentivised a lot more as well.
Yeah, that's interesting, because it's kind of like I spent too long in the US healthcare system, and there, of course, you have got the incentives are quite in terms of let's test you more and more and charge for all these tests, but surely the advantage of a system like the NHS should be able to do more population health management and actually get paid for it properly. Yeah. Okay. All right.